After- Good afternoon, everyone, and welcome to our live webinar from Voxels to prescriptions and beyond. This is hosted by SCCT and Elucid, and we are excited to have you join us today as we deliver what we think is going to be a future of atherosclerosis-based management of cardiovascular risk and disease. We are extremely lucky to have an extraordinary panel with us today from all over the world, and I'd like to briefly introduce them now. If we don't do a brief introduction and go to detail of each of these individuals, it's going to take the entire hour of the webinar. So I just do the brief introduction with your permission. We are going to have Dr. Rasha Al-Lamee, who's actually currently scrubbed in the case and will join us as soon as she's finished with the case from Imperial College London. As it doesn't require any introduction, Dr. Al-Lamee was the leading authority and author behind the series of orbital trials, which was earth-shattering basically in the world of invasive cardiology, and has recently been the Lancet commissioner, calling for a fundamental shift on how we approach coronary artery disease from ischemia to atheroma. Next, it's my privilege to introduce Dr. Bon-Kwon from Seoul National University. Dr. Koo is a professor of cardiology whose pioneering research on coronary physiology and imaging has significantly advanced our understanding of clinical implications of CT and treatment of coronary artery disease. I have to thank him extra compared to other people because in this panel because it's 2 a.m. in Korean time, and he's smiling and he's looking great, and I really look forward to listening to his thoughts on the subject. And finally, I'm very delighted to introduce Dr. Jacket Nerula, who doesn't really require any introduction. He's from University of Texas, Houston. He's the president at World Heart Federation. And beyond being globally renowned figure whose expertise span from molecular imaging to CT imaging, vulnerable plaque detection on CT imaging, Dr. Nerula has been my personal mentor for the past 10 years and someone who I've learned immense amount of information about coronary artery disease, cardiology, and beyond. So with that, I'm very excited to start this webinar by sharing some of the slides to open the discussion about the topic that we have today, from voxels to prescriptions and beyond. And we're going to do that by basically going over a case that I saw about a couple of months ago in CCU. It was a 48-year-old male real estate agent, no known past medical history, that had an LDL of 98, A1C of 5.5, no hypertension, an ASCVD risk score of 2.7%. He plays regularly, plays tennis regularly. He doesn't have any chest pain. He doesn't have any shortness of breath. And if I saw this guy in my clinic or according to guideline, I should probably just reassure him he doesn't require any medication based on this risk profile or further imaging. But I didn't see him in a clinic. I saw him, unfortunately, in CCU when he presented with a sudden onset of chest pain after his dinner. He came with this ECG. Obviously, he went to cath lab, and we found what we found, which is a 99% thrombotic occlusion of his middle AD. Thankfully, he got revascularized, and his damage to the myocardium was not that severe, and he recovered well. But it bears the question for us as was this a rare event or could it have been prevented? And that brings us to thinking about our work frame in cardiology. Still in 2025, what we do in the clinic is one of these five things. We either reassure people, ask them to change their lifestyle, we start them on medical therapy, or we send them for some non-invasive testing or invasive testing. And we do that based on either risk factors or symptoms. And we do that to prevent heart attack or to relieve their symptoms and improve their quality of life. But the question is, when you think about this paradigm, which is a simplified way of actually what many people are doing their practices now and what guidelines are suggesting us to do, is that the question is risk factors and symptoms good gatekeepers? And we've shown this actually last week. This was published in JACC Advances with myself, Dr. Narula, and Dr. Anna Miller, and other colleagues, that if you see patients that present with their first heart attack, and we had 465 of them that are below age of 65, and you assume that you would see them in the clinic 2 days prior to that, with ASCVD risk calculator, 45% would not be recommended statins or further imaging. With prevent calculator, 61% would not be recommended statin or further imaging. And with regards to their symptoms, about 60% didn't have any symptoms whatsoever 48 hours prior to their presentation with MI, concluding that about half of the patients will be missed with our current practice of guidelines, which really ask for a shift in the paradigm that we do, which is a risk factor, risk estimate score, symptom paradigm or ischemia paradigm. And we need to go towards something that is more robust. And the reason for that is potentially the fact that yes, risk factor, ischemia, and symptoms are important, but when you look at the population, the amount of patients that are low to intermediate risk, non-ischemic or non-symptomatic, is much larger. So when you think about MI and go backward, it's much more prevalent to have MI from patients that are low to intermediate risk or non-ischemic or non-symptomatic up until the time of their MI. And this is what I call the MI paradox. So in order to resolve such a MI paradox, I think the action that Dr. Al-Lamee made to call in the Lancet Commission of moving from ischemia to atheroma is very, very important. While we are waiting for Dr. Al-Lamee to describe this in more detail, and I'm hoping that she'll be able to join us in a few minutes, I will turn the page to Dr. Narula, and I stop sharing my slides, asking Dr. Narula, as the person who basically brought into the field the concept of high-risk plaque and vulnerability from histology to CT scan, if we want to use CT scan as a guide for us to detect atheroma and to treat patients with atheroma, what are the features that are important that we need to pay attention to? Dr. Narula.
Thank you, Amir. You can see my slides?
Yes.
Perfect. I'm truly honored to be here in the company of Rasha and Kwon and Amir here for this SCCT webinar. And what Amir really wanted me to do was whether can I bridge between Rasha and Kwon and really focus on what exactly we should focus on for atheroma in CT angiography. So as he said, that from histology to CT, and if we could really use the better term here, can we really call it a virtual hictology instead of virtual histology here? So, well, how does it all start? We have been talking about ischemia. And what did we talk about ischemia? Long ago, about 50 years or more ago, when Dr. Gould suggested that 70% occlusion of a coronary artery is important. It was those days when we talked about the 70% occlusion in a dog where there is a significant collateralization, a single artery which was tied with a ligature down to 70%. And then we had all these significant mega surgical trials where we compared the revascularization with the optimal medical therapy and demonstrated that the surgical revascularization did well. It reduced the ischemia, it reduced the symptoms, and it created something of a paradigm there where we said that if we are able to diagnose the stenosis, then to detect the stenosis, we will need to find the ischemia, and then we will revascularize them. And we hope that everything will be fine because it is the ischemia that leads to the bad outcomes, which could be myocardial infarction or death. Now, the problem is that in those days, when we looked at these lesions, 70% lesions, at that time, these lesions were juicy lesions. If you really look at them, they were significantly full of the necrotic core. The reason is that the optimal medical therapy of those times did not have statins, maybe some beta blockers, maybe some aspirin at that part in time, and forget about the recent other repertoire of the medicine, what we call as the optimal medical therapy. Now, if I really have to look at the entire spectrum of the coronary artery disease, and which is what exactly the Rasha's presentation is going to be, that every single lesion should be an actionable lesion. That we start right from the beginning when we have the early lesions, which might be so called even the non atherosclerotic lesions, but that is how the atherosclerosis starts. And then there will be the lesions, which would still be reversible lesions, and then going into more advanced lesions, which could be the early fibroatheromas, late fibroatheromas, and then the thin cap fibroatheromas, which lead to the acute events, whether they are through the erosion or through the plaque rupture. And as we know, that predominantly the lesions are the plaque ruptures, which will happen in up to about 70% of cases when it is myocardial infarction, and in a minuscule, it is the calcific nodules. So these which we talk about the early lesions, which is the Rasha's concept of going from coronary artery disease to the atherosclerotic coronary artery disease. And then what Bon-Kwon will be telling you is as to what are those advanced lesions where we should be intervening. Well, when we talk about the ischemia and we talk about the morphology, there was a significant revelation from the FAME2 trial. When we looked at the extended outcomes of the FAME2 lesion, 50% at 5 years of the patients who were on optimal medical therapy did not have the myocardial infarction, did not die, they did not need revascularization, and their relief from angina was same as that of revascularization, suggesting thereby that it was only about 50% of those cases who had abnormal FFR. Those were the people who really benefited from revascularization, and that too in terms of the need for revascularization, not in terms of the myocardial infarction or death in those cases. And in a very elegant design, Samedi et al., when they reanalyzed or they did the post hoc analyses of those who were treated optimally with the medical therapy in spite of the abnormal FFR, they demonstrated that it was the wall shear stress that was able to tell those patients who resulted in an event as compared to those who did not have an event. And those had an increase in the proximal wall shear stress, suggesting thereby that they had the morphologically different lesion or so-called vulnerable lesions. Now, can you identify these lesions as by the non-invasive means? And that is what we call as the virtual hictology here. Yes, that was the earliest of the papers with working with Dr. Takeshi Kando and Sadako Motoyama, and comparing them with the intravascular ultrasound, we were able to suggest that looking at simple Hounsfield unit densities, you will be able to tell the necrotic core from the fibrous plaques, from the calcified plaques, and that there was a one-to-one relationship. And the question was, what exactly should we be looking for in these lesions? So working with Dr. Virmani, we demonstrated looking at 300 hearts, where we looked at 100 ruptured lesions, 100 vulnerable lesions, and 100 stable lesions, we found that the most important differentiating factor was the fibrous cap thickness, which obviously requires the intravascular imaging, quite like the optical coherence tomography. If we do not have an availability of the fibrous cap thickness, there were two most important features that come out to be important. These are the plaques which are ruptured, which are the red plaques. The blue are the ones which are vulnerable plaques, and green are the plaques which are stable plaques here. And the most important two features that differentiate the stable plaques from unstable plaques are the presence of inflammation and the size of the necrotic core. Now, when we looked at those people who had had the evidence of the acute myocardial infarction, and we were able to do their CT angiogram before they were taken to the cath labs, because these were the ones who had presented with the low risk after 24 hours of having the chest pain, we identified that there were two most important features there. One, which was the presence of the necrotic core. As you can see here, the Hounsfield unit densities of less than 30. And second important feature was the positive remodeling, both the features which were not present in the plaques that were stable plaques. And we called these plaques as two feature negative plaques, while these were two feature positive plaques in this particular case. Now, the positive remodeling, although that when we were analyzing these by the histology, we did not find the positive remodeling as important because these were not the living arteries, and we are not able to see the positive remodeling as the arteries collapse in these cases. And why is it that it is important? And this is one of the papers which has just been submitted to JACC Imaging in collaboration with Dr. Virmani. We've demonstrated that the positive remodeling is important when it is fibroatheromas and not in the pathological intimal thickening, which is the earlier lesion, suggesting thereby that lipid core here also might be present, but you need to have the positive remodeling so as to demonstrate that we are in the advanced stages, suggesting the importance of the larger necrotic core in these cases. Inflammation now has become possible, that it could be identified by the CT angiography, by the added PET scans on top of it, such as the FDG imaging after the ketogenic diet for 24 hours, or now as the fat attenuation indices are being proposed as the presence of inflammation. How exactly would it add on top of the necrotic core? We still need to see in the head-to-head comparison of such demonstrations. Now, as you could see here, that if one looks at those plaques, when 1,000 subjects, when we had followed them for at least 2 years, there was 45 times higher likelihood of having an event if there was a two-feature positive plaque as compared to the two-feature negative plaque. That holds true. Even if there is a 10-year follow-up of 3,000 subjects, you'll see that the high-risk plaques, that is those with the two-feature positive plaques, have a significantly greater likelihood. That is about tenfold higher likelihood of having an event as compared to the non-high-risk plaques. Although the non-high-risk plaques now do not seem to be as benign as they were at the 2 years as we saw earlier, because some of these plaques are likely to progress to become the high risk plaques. And we were able to see in those where we had the sequential assessment of these plaques that only those plaques eventually result in an event where there is a plaque progression, leading us to believe that plaque progression is a necessary feature of the plaque vulnerability. And a statement that was very dogmatically presented by Amir in one of his very elegant editorial opinions in Journal of American College of Cardiology. And it so happens that at the end of 10 years, just because the tenfold higher plaques at the given time in a cross section are the non-high risk plaques, and even if they have tenfold less likelihood of having an event, at the end of 10 years, the plaques which rupture from the high risk plaques, the number is the same as that of the non-high risk plaque, suggesting thereby that identifying those plaques which are likely to have a plaque progression becomes extremely important. Now, there have been multiple new terms which have been suggested: three feature positive plaques, four feature positive plaques, and so many other features have been suggested. For example, some which are called the napkin ring sign, or those which are called the signet ring sign, and they are essentially the large necrotic cores, quite like suggesting that there is a plaque progression. As you can see here in these cases, that whenever there is a plaque progression, there is a likelihood of having an acute event in these cases. So as a matter of fact, it is just an extension of plaque progression. And the same thing happens when we talk of the calcification, that whenever the calcification is going to be representative of having an event, there is a greater likelihood of macrophages being there. And as the macrophages start to die, they start to become the nucleus for development of calcification. And then, as you come to Dr. Ku's data and then compare it with what Amir has worked based on the NXT trial of Bjarne Nogard, he came up and suggested that the as important as the luminal stenosis is, the low attenuation plaque volume is equally important when it comes to the FFR assessment, or suggesting thereby that the FFR starts to become abnormal when there is a there is a large amount of low attenuation plaque, again suggesting that it is the plaque progression which becomes important, leading us to believe in the Glagow's hypothesis once again, that greater the necrotic core, greater is the likelihood of having an event. And would there indeed be a possibility, as Dr. Koo will present to you, that would we be able to identify the plaque at the baseline? And would we be able to identify that if the circumstances remain the same, would we be able to identify at which rate the plaque is likely to develop? Is it going to be a fast progressor? Is it going to be a slow progressor? At what point in time would there be a likelihood of plaque rupture? And I will let him explain that concept to you. But let us just consider two scenarios so as to seal the conclusion here, as what Amir started with his patient, that there was a president of United States of America who in 1992 demonstrated that he was able to go to bruise stage 5 with 91% of maximum targeted heart rate and having no ischemia. In 1999, cholesterol levels were pretty normal for those days. And in 2001, there was a significant increase. And then there is no information in the public domain until he developed an unstable angina. I believe that he continued to have the stress test in these days, where all these stress tests were normal, but still had an acute coronary event and required an emergency quadruple bypass surgery. We did not know that he had a coronary disease, but he developed an event, quite like what Dr. Ahmadi just presented in his patient. And then a story of another journalist from United States who was found to have some calcium in 1998. 2008, he was subjected to the stress test, did exceptionally well on the treadmill test there, and essentially has been on some small dose of statins and the antihypertensives. And 6 weeks after having a normal stress test, he died suddenly in studios when he was interviewing a president there. What went wrong here? He had a coronary artery disease, but he had a negative ischemia. So, bringing the entire concept from Dr. Rasha Al-Lamee to Bon-Kwon as to which are the actionable lesions when it comes to prevention versus those when the lesions have advanced, and which are those which are likely to have an event and where we should intervene or where we should treat them with the medical therapy. Thank you very much.
Thank you very much, Dr. Narula, as always. Amazing presentation, amazing overview of the history of this concept. I now have the opportunity to introduce formally Dr. Al-Lamee, who's joining us from London, Imperial College. She was scrubbed in the case, so fresh off the lab and and ready to tell us how we can prevent these events that end up in the cath lab. So, without any further ado, Dr. Al-Lamee, thank you very much for joining us.
Thank you very much, Dr. Ahmadi. Thank you so much for the introduction. And also importantly, thank you very much to Dr. Narula and Dr. Ku for being here. I'm so sorry I was so late. So we today are kind of talking about how we can fix the growing problem, but I'm going to discuss maybe a little bit about where I think we are now. And in particular, hopefully do you see my screen?
Yes,
Perfect. And in particular, what the focus
it
was
says
for
you're
our lab.
sharing, but it doesn't actually
Oh,
have the screen for me.
okay.
That you started the sharing.
Okay, try again. How about that?
Now it's there. Thank you.
Perfect. Um, So we're going to talk a little bit about the Lancet Commission and kind of what we did. I've just come out of the cath lab having just treated a primary angioplasty in an 85-year-old man who has clearly had decades of coronary artery disease that has developed over time and has been entirely asymptomatic until the point of his presentation today. And what's interesting is to see the many lesions that he had in his coronary and the one lesion that ruptured. And I guess the question is, what causes one lesion to rupture and cause a problem, and what causes the others to just gradually stenose over time, collateralize, and not cause a problem? And this is really what we thought about within our commission. But ultimately, what happens in a commission is something very different to what we normally deal with, which is that we were told, you tell us about the problem, and then you think about the way that you fix the problem, but you have to think about it in a global sense. You don't think about it in the sense of what you could do in the US or Europe, what you could do at the sort of, the end of healthcare where perhaps finances, etc., are not so challenged, but actually what you could do to increase equitable access to healthcare, but also to improve outcomes throughout the world. So we kind of went back and sort of thought about things. And if we remember many decades ago, editorials like this, things that came out at the point at which we had had lots and lots of very, very innovative LDL lowering therapies, in particular statins, and importantly, a real focus on what cholesterol meant for our patients and how this was causative in coronary artery disease. And here you have an article in Science that says, this is it, we have the cure, we have statins. Surely heart attacks will be gone within a century. But as we know, despite that progress, they haven't gone. And what's interesting is they say here, 4 decades of progress in understanding cholesterol and lipoproteins might now mean that we can fix the disease. And now we look 3 decades on, and ultimately we've not made the cure. If we think about the United States just in itself, you can see that actually one person dies every 34 seconds. In 2023, 900,000 people died of cardiovascular disease. And importantly, hundreds of billions of dollars are spent every year. And so the commission was around thinking about how we tackle coronary artery disease. And at first, it was quite tricky because you think about all the various commissioners and what they think about as the way to tackle coronary artery disease. And it was very important to amass a group of people who thought in different ways. So people in prevention, in imaging, in intervention, but also in public health, in healthcare delivery, and also in economics. And those different people think in different ways. And of course, I'm an interventional cardiologist who's trained to think about what we do in a cath lab. But very early on, it became clear to me that what we do in the cath lab is actually not going to make the cure. If we actually think about what we do even in clinic, I think we think about things the wrong way. We think about atherosclerosis as an inevitable part of aging. In fact, our risk calculators deliberately tell us to put in the age of the patient, and the calcium score that we might get will be the risk of that calcium score, or how important we think that calcium to be, will be adjusted based on their age. And so as a genuine sort of basic concept, we think that the development of atherosclerosis, the development of calcium in our arteries, It's just part of what happens as we grow old. And I would argue that that's really not necessarily an inevitable part of aging. And in fact, when you look back at the data, what we can see is the majority of people who have an MI have absolutely no symptoms, and this is in the US, are not taking preventative treatment. And the vast majority, as you can also see, not only did they have no symptoms, but also a significant proportion, 1/5, have not seen a physician. So the people who come to us with acute coronary syndrome are not the same people that are sitting in our cardiology clinics, maybe not even in our prevention clinics. And importantly, they're not going to their primary care physicians with problems. And so what we know is that while at one point coronary artery disease mortality seemed to be slowing down, it's rising again. And where it's rising most is in the developing world. And that's where we're seeing a really large increase in cardiovascular disease prevalence, but also mortality. And our modelers within the commission did some modeling, and what they found was that in 2050 we would have 10.5 million deaths globally per year from coronary artery disease. There'd be a 4.2% rise in upper middle income countries, and importantly, a nearly 20% rise in lower middle income countries. So you can see just how much this is going to be a problem that encompasses the whole world. Importantly, or even as we speak, there's a global heterogeneity in mortality rates, and that's only going to get worse. In some areas, things will improve. In Europe and now North America, we expect mortality rates to go down. In other areas, it's really going to increase. And what we also see is that the deaths due to risk factors will rise. So hypertension, dietary risks, LDL, the things that are very, very preventable are the risk factors that are likely to rise in these patients. Importantly, that much of this data came from the global burden of disease models, and some risk factors, which I think might be significant, things like physical activity, are very hard to get data from these big data sets. So there are aspects of this that we really couldn't model as well as we would like. So the leading modifiable risk factors, well, by 2050, we think pollution will be a big one. Sodium intake is going to be a big one, and then obviously LDL and blood pressure, as they have been for decades. So, what does it matter to our funders? Well, I think it's really important to think about beyond just the health of our global world, but also financially, we currently spend 27% of our spending on cardiovascular disease, on coronary artery disease itself. Currently, that's $1.66 trillion. By 2050, that's going to go to $2.6 trillion. So if we're trying to get our funders to care, these are some of the metrics they might care about. So we had a number of objectives, but I think I will just speak to the most important objective, which was to reduce the global burden of mortality and morbidity from coronary artery disease. And I think Professor Koo and will also speak to this. Importantly, we thought that we had to think about the personal, societal, and economic impact of this disease and reduce that. We have to think about future research in coronary artery disease, but also we need to be able to encourage global collaboration. And of course, in order to do that, we have to get lots of stakeholders, including our patients, together towards a common goal. So I won't focus too much on every bit of our strategy, but ultimately there are a few key parts. One aspect we felt was that ischemia is the end stage symptom of a disease, if you could say that. So it's what happens after a disease is developed, and now you have an issue with demand-supply mismatch. Actually, it doesn't tell us about the burden of the disease, or more importantly, it doesn't allow us to catch the disease early enough. And so we thought it was time to actually just refocus how we think away from ischemia and towards atheroma. And even in doing that, think about atherosclerotic coronary artery disease, not ischemic heart disease. We wanted updates to the ICD-11 codes, and that would involve coding that would recode coronary artery disease towards atherosclerotic coronary artery disease and include coding of the stages of disease, because again, that would allow us the ways to intervene at earlier stages. And importantly, and Jagat just spoke to this, we wanted to think about a lifetime continuum, to think about the disease from early life to older age, because we know atherosclerosis begins in the young, and there was data decades ago showing us, yes, we often see our patients when they're in their 50s and 60s and older, but if you go back, you can see the prevalence of coronary atherosclerosis is actually not insignificant in our teenagers. And as the mum of a 14-year-old with significant family history on my side and my husband's side, this stuff starts to become important to me. I think if most adult members of his family are on statins on risk prevention, why do we have to wait till he's in his 50s before we think about it? And so as part of that, and again, we can speak to this, we wanted to think about how we consider prevention in before birth, even in early life, as our children become older, how we think about diagnostics and therapeutics, and then in adult life, what do we think about in terms of serial diagnostics, so that we can intervene with therapeutics that might stop progression of disease. Obviously, we know there are lots of risk factors that are modifiable, and that as an entity, this is a preventable disease. And we again modeled what would happen if we actually dealt with these risk factors. And ultimately, what we spoke to was early diagnosis of risk factors, personalized approaches, because of course, different risk factors affect different people in different ways, identifying novel risk factors, of which there will be some, and then importantly, starting to define the outcome associations. So with longitudinal studies that allow us to understand how these risk factors impact the long-term association with disease. And of course, a key part for us was early screening and detection. And it's interesting when you again look back at that editorial in 1996, they said then that in the proof of concept of a cholesterol hypothesis, we need to be able to think about the challenge was to develop non-invasive screening tools to detect atherosclerosis in its early stages. And that was then. And we still don't have, at this point, enough of that going on in my mind. So we spoke a lot to screening strategies and what we might do. But importantly, those screening strategies have to be equitable. And I think this is another key factor. It's not enough to now have lots of highly sensitive diagnostic tools in places where we can afford it, while in the rest of the world, this isn't available. Implementation is going to be very important. And what we saw from our modelling is that if we just do what we know already, there'll be an 82% reduction in deaths from atherosclerotic coronary artery disease by 2050. Of course, this is modelling and it has its complexity, but even if 82% isn't what we achieve, we can have a significant reduction in deaths in the next 3 decades if we just do what we know. We wanted to think about addressing global disparities in care and outcomes, because as I said, what we're going to see is those deaths, that red area that we see in the Northern Hemisphere now will spread south by 2050, and we'll see much more death from this disease in the developing world. And that tackling these disparities is going to be really, really important. And to that end, we need to think about standardized data collection and research that we can do in communities across the world. Eradication of atherosclerotic coronary artery disease we felt was possible. So new therapies, the gene therapies, what I'm calling the vaccines for atherosclerosis, there probably, hopefully, is something out there, and we must take lessons from our oncology colleagues and our colleagues in infectious diseases who've really changed the world. So it's important to think about how we discover those. And most recently, we saw trials such as Vesulius that was presented obviously in AHA that showed us that PCSK9 inhibitors, finally are starting to have maybe some impact on major adverse cardiac events. So what's next? Where do we go? And importantly, how do we provide therapies that are are available from a cost perspective, but also from an implementation perspective? Data collection is obviously going to be very important. And again, just to go forward, so is the workforce. So interventionists like me, I think, need to start to be trained in early detection and prevention. We all need to see prevention as part of what we do. And that's going to involve us moving prevention away from silos to the whole atherosclerotic coronary artery disease workforce. Our cardiothoracic surgeons, our vascular surgeons, they need to be trained in prevention because we will then be able to implement change, but also we need to be able to deliver healthcare closer to the patient. It's not enough to think about models just in hospitals. And then finally, I'll end with the sort of elevator pitch, which is that we need to increase research funding because it's time that it matched the global burden of the disease. Unlike oncology and infectious diseases, where research funding really does match global burden, in fact, in infectious diseases, it outstrips the global burden of disease. This is not the case in cardiovascular disease. Our research funding in no way matches the global burden of disease. And in fact, we are akin in the UK, we got the stats this week, to mental health disease in terms of the research funding and its a proportionality to the burden of disease. So I think I'll stop there because I just want to end with the future. So we felt that to save 8.7 million lives per year, this was the kind of, the moonshot. Early detection and elimination of risk factors, early identification and treatment of disease, transformative discovery science, and importantly, equitable access to care. And so finally, I come to the brilliant editorial that Jagat wrote that really talked about how we will change things. We'll go from detecting stenosis to detecting plaque. Testing for ischemia will change to actually thinking about how we modify or stabilize disease. Instead of just thinking about revascularization for everyone, we'll be revascularizing appropriately, mainly for symptoms. And importantly, and to change outcomes, we'll be less focused on symptoms and more focused on finding and modifying the plaque. And so I will kind of stop there and allow us to go to discussion or Dr. Ku's presentation. Sorry if I went a little bit over.
Thank you so much. That was brilliant as always, Dr. Al-Lamee. Very important shift, paradigm shift in the field from symptoms, ischemia to atheroma and detecting the disease as opposed to guesstimating it. So it seems like we are moving to that direction that we have to have screening. And the question for Dr. Ku now is that it seems like symptoms are not very good gatekeepers. So are we there yet to start thinking about screening for coronary artery disease by CT scan, independent of symptoms? And what if we find lesions that are very ugly? Should only symptom be the driver for, I call it a series of local therapies, not just revascularization, but all the emerging therapies that are coming that locally will intervene on a lesion that is about to rupture or cause event? Or should it be something in the plaque itself? Are we moving from this stable ischemic heart disease, which is symptom-related stable, to stable atherosclerosis heart disease concept? And Dr. Ku, all yours.
Okay, so can you see my slides?
Yes.
Okay, so thanks Amir and CCT and Elucid for giving me a chance to be involved in this webinar. And I also thank Jagat and Rasha for making an excellent introduction and background about this issue. So I'd like to start with symptom. So if symptom-based approach is enough, we cannot see this kind of a data, although it's a kind of 10-year-old data that when you see the proportion of sudden cardiac death, we know that the 2/3 first event only had minimal risk factors and only 1/3 had a previous diagnosis of CAD. So we also discussed these important papers just published a few days ago and was highlighted by many media that the current risk calculator miss many of the patients. And when we also see the other country-based data, subclinical CAD, even though no patient had a symptom there, but the presence of any subclinical coronary artery disease, regardless of symptom, increased the risk of MI almost 3 times. And when even asymptomatic, when there's obstructive extensive disease, risk for MI increased as high as 10 times than the non-coronary artery disease. So previous two speakers already, more than enough elegantly demonstrated that the why we should change, and we should change our focus and paradigm from ischemia to plaque, because that the significant portion of MI and sudden death present as a new coronary event without any symptom. But it was not because of they don't have lesions, but they had lesion but no symptom. But the problem we have is that even if we had a pre-screening, the question is we don't know how to treat and how to predict the risk of ACS. So that's how I'm going to deal with these cases. So these are two cases having lots of disease. So assuming that these two patients are destined to MI, as an interventionist, my practical question is, can I identify the future culprit lesions to put a stent on there? But I know that it's very difficult to do. So that's why we're here. So I like to start with this case, asymptomatic, relatively young, but found to have a CT scan at the time of routine health screening. As you can see in the CT scan and the angiogram, there's a significant stenosis, high plaque burden, as Jagat elegantly demonstrated. This is a very soft low attenuation plaque with positive remodeling. So the question is this luminogram, either CT or angio is enough, or should we do a physiology and should we do a imaging-based decision making? So that's a very practical question to me and also the outpatient clinic management. So some may argue that the answer is very simple. We know that the physiology guidance is class 1A indication in all the guidelines. So we should measure FFR and do the medical treatment of PCI accordingly. So that's the current recommendation. But unfortunately, we now understand that as this is stressed throughout these meetings, that the ischemia may not be a gold standard anymore, because that the ischemia trial designed and performed to prove the benefit of ischemia-directed preventive ischemia-directed revascularization, but it failed to prove its benefit over initial medical treatment. And there are several successive so-called failure of ischemia or the ischemia-directed, surrogate-directed indices, including PREVENT trial with harsh critics about the FFR and functional stress test. So it is natural that people think about the substitute for the concept of ischemia, and I think that that may be the vulnerability in a right direction. I think that the vulnerability-based treatment and decision-making is excellent, but it also has some problem. And as for the vulnerability matter, Jagat elegantly presented the CT-based vulnerability, and here are the data on the cath lab-based invasive assessment-based vulnerability assessment. And we also have a very elegant meta-analysis data that regardless of invasive and non-invasive imaging, high-risk features or vulnerable features are associated with the lesion level and patient level MACE. So some may say that the physiology-based decision-making is a yesterday decision, but tomorrow we have to do imaging-based decision-making, as this patient had luminally significant disease, high plaque burden, volume plaque. So interventional cardiologists want to put a stent there while citing the PREVENT trial. But as you know, challenges every day. So the problem of the vulnerability is we still do not know how to clearly define the vulnerability, and we do not know whether the fixing those lesions with the local treatment such as stent really beneficial in terms of patient outcome and also the cost effectiveness as well. So here's an exemplary data. So this is an Emerald 2 study where all patients had acute coronary syndrome and only 30% had a symptom. So most of these patients were asymptomatic, but all of them had acute coronary syndrome. So when you assess the physiology, plaque quantity, quality, numeral layering, there's several differences in the prediction ability and the discrimination ability. When you simply focus on PPV, you see that the local hemodynamics or the delta FFRCT across the lesion has the highest PPV, followed by the other imaging probabilities. So as shown in the PREVENT trial, if we simply follow the imaging, maybe there's a high chance of overtreatment. So luminogram may be not enough. Physiology have some caveats, and imaging also have a problem. So the question is, what should we do? Maybe I think the problem can be fixed while we're combining all these insights. So here's a case, LADFFR negative, but the small lumen, high plaque burden, high-risk features, partial remodeling, neck and ring size, spotted calcification, and later the patient visited ER with the progression of the proximal LAD disease. And the reason why I stress the importance of this CT scan is we cannot do all the invasive imagings, all the invasive physiology, but now we have a tool to assess all these hemodynamics, lumen, plaque burden, plaque characteristics using one CT scan. So we once analyzed our data with the CT scan, found that the presence of the local disease burden, plaque characteristics, global disease burden, and presence of ischemia, either by invasive or non-invasive image-based physiology, when we add one by one, we have a better ability to discriminate the patient outcome. So it's easy and good to say that when we combine all the insights from physiology and imaging, we can have a better discrimination and better selection for the patients in terms of treatment decision and prognostication. But the problem is that we have so many different indices in terms of physiology and so many different parameters and combination in terms of imaging. So the practical question is how to integrate imaging and physiology in daily practice and when. So that's the practical question we have to pursue for coming years, I believe. And here's an exemplary so-called practical algorithm to define high-risk lesions using a CT-based approach. So I don't think this is practical, but we have to make this algorithm by the request of the reviewer. So the question is how we can fix these issues related to this instead of these algorithms. I think the AI will be the future. So you're looking at two cases, old lady, relatively young patients, but by the CT scan, it looks all the same. Focal disease, obstructive lesion, FFR positive, high-risk lesion. But if you ask AI to interpret these two patients using risk prediction model, individual risk prediction based on explainable machine learning. This is AI's interpretation. This upper panel, old female has a very high risk, and the lower panel, relatively young patient have a low risk, despite the same discrimination by current criteria. And what happened to these two patients? About patients 6 months later, ACS and relatively young patients under medical treatment, nothing happened. So in a relatively short time, I briefly mentioned about the strength and weaknesses and current status and future of how we can assess this kind of asymptomatic patients. So I can make a kind of broad summary that the physiology imaging are not good enough, integration may better, but definitely we need AI-based technologies based on especially non-invasive tests to define risk of the patients and prognostic time dependence, and also the treatment of right strategy for the patient. Finally, I'd like to close my talk with this, what happened to this patient. So again, significant luminal narrowing, high plaque burden, volume plaque, but FFR negative, delta FFR borderline. So if I follow the PREVENT trial, I have to put stent there to reduce the risk of the recurrent ischemia or revascularization. But I decided to do a medical treatment, statin, clopidogrel, and several years later, took the follow-up CT scan. And what happened to these patients? There was nothing. Complete regression happened. So we have to find how to treat these lesions. We know that this stent is not the right answer for this, and we have to define who will be the right candidate for this kind of medical treatment. And there are many things for us to do. Thank you.
Thank you so much. That was an amazing journey from what we currently do to atheroma that Dr. Al-Lamee said, to what to look for the atheroma by Dr. Nerullo said, and then how to combine physiology and morphology independent of symptom to guide our treatment. And I just wanted to complete the hour by just showing that based on what I've learned from all of you and what we are trying to do in Elucid is that we are having this AI predict study that will be commencing early 2026. And what we are trying to do is exactly what Dr. Ku just mentioned by looking at 170 MI cases and 510 3-to-1 control to case with MI, people that had CT scans, and looking at all the physiological, local physiology, as well as local morphological features, such as the LRNC size and volume, such as whether or not there is a calcified cap, such in terms of the physiology, the vessel level FFR, but more importantly, lesion level delta FFR, potentially wall shear stress, and other factors, and give it to AI to be able to do the risk prediction. And I think where the field is going is to look at not only the presence of overall plaque burden, but individual plaque characteristics and risk, the change of plaque over time, as we saw in that case, and risk factors, but not risk factors to initiate treatment, but risk factors as a situs of treatment that we can use to treat those plaques. And we need to understand what these medications are doing to our plaques in terms of stabilization. We need to have granular data. And in order to do that, we are planning to do a series of studies called HALT studies to look at the optimal LDL reduction for plaque stabilization purposes, whether or not colchicine on top of LDL is needed, whether or not GLP-1 GIP agonist on top of LDL reduction will be useful, or LPA therapy on top of LDL reduction will be useful. So the way that we see this field going forward is that instead of risk factor symptom gated basically paradigm, we are going to comprehensive plaque analysis. Our medical treatment will be shaped by overall plaque burden, individual plaque features and risk, and delta plaque change over time. We need to understand this middle part of this curve in order to figure out what's the best way that we can, what's the best way that we can treat the person individually, but also be able to, I don't know if you're seeing my screen or not. Let me share again.
We saw it.
There we go. But also to look at local physiological measures and high-risk features to be able to drive local therapies if they proven to be in future, if they prove to be useful for not only predicting preventing symptoms, but in certain cases to prevent MIs. And I don't think the future of local therapies is only PCI, but I think there is an interesting growing field about cryotherapies, drug-coating balloon, and BVS that we need to remain open to see what the effects are. And in order to just go over this concept with a case, I just wanted to point out about two cases that, based on the clinical information, they're almost identical. Based on their calcium score, they're in a similar category. Based on their CT, plaque, and FFR, they're in similar category. Both are CADRATS 3, both total plaque volume are between 250 and 750. The FFR is mildly positive in LLD and negative in the other vessels. But then, even if you look at the delta FFR, is about the same. So you think that these people up to this point are exactly the same. But then you look at the combination of morphology and FFR, which is a very important predictor. And you go there, and the first case is a very vulnerable plaque with a high level of lipid-rich necrotic core. The other case is completely calcified. And even though I don't have the literature to support this, but my feeling about this case causing FFR positivity versus the other case of, pardon me again, I don't know why it causes share problem. With the other case of FFR positivity is completely different. In one, you don't have the features of vulnerability, and the other you do, and it's the same FFR reduction. So I think a lot of exciting developments are coming down the pipeline in terms of the imaging technology, in terms of using and utilizing AI to understand risk, but also in terms of treatment. And I wanted to thank the panel for this wonderful discussion, and I wanted to give opportunity to each of individual panelists to share their final thoughts about this before we close the session. Maybe we start with Dr. Narula. You're on mute, Dr. Narula.
It was a fabulous continuum, Amir, from Rasha to Kwon, and a complete whirlwind here. One important thing that I would like to end with is that we just presented the Century trial, as you might have seen in the European Heart Journal, came about a month and a half ago, where the people with severe double vessel and triple vessel disease, they were randomized to receive the optimal medical therapy versus aggressive optimal medical therapy to target, or the patients treated to target. And as a matter of fact, in their 5 years follow-up, they were seen or they were contacted about 350 times, suggesting thereby how close the follow-up was and how aggressively the management was, and essentially treated to the goal. You would be surprised if I say that with the optimal medical therapy, these folks demonstrated a 41% reduction in death, 37% reduction in death or myocardial infarction, and 34% reduction in revascularization as compared to even optimal medical therapy. So the way you have suggested, I mean, even with the severe disease, and we, as we always say, that the medicines that we have now, they are mighty and they can really make a difference. And with some of the terms that you commonly use, and I've heard you using those terms, that would we be able to go for the selective lesions where we will be able to intervene, what you fondly call as polypectomies, is something which I feel would be the future. And as Rasha so elegantly said, that would we be able to eradicate the disease? I think yes, that's indeed the future. It is a disease of our making, and we must take care of it. Thank you.
Thank you, Dr. Narula. Dr. Al-Lamee, any final thoughts?
No, thank you very much. I mean, I think as an interventional cardiologist, I've been really humbled by how much what we do in the cath lab isn't, the be all and end all for many aspects of different trials that we've done and now looking at the commission. And this is why I have now started to refocus what I do. But the other opportunity I think interventional cardiologists have is the moment one of your patients has come in having their primary angioplasty, you often sit in a waiting room with their relatives. And it's a great opportunity to focus all of their minds. And so that's one of the new things that I've started to do. And maybe that's the focus of a trial one day.
That's wonderful. Thank you so much for your contribution to the field and for elegant talk today. Dr. Koo.
Okay, so I think this is a great webinar. So I really love Russia's Lancet Commission paper, because it's really the time to shift our focus from the ischemia to the plaque and its association with the event. So because I learned from my teacher, it's a continuum: plaque, ischemia, and symptom, event. As an interventional cardiologist, our work is for the symptom relief, ischemia relief, but when we only focus on that, we cannot fix the issues related to sudden cardiac death and ACS by showing the several cases. But one thing I'd like to stress is that I discussed this issue with Rasha last year during EuroPCR, that as an interventional cardiologist, when I say we should focus on plaque, that means sometimes to some interventional cardiologists is that I have a green light to see all the plaques when I see by the OCT and blah, blah, blah. So that we should be very balanced, thinking about the cost-effective issues and to find the right vulnerable plaque and stress the importance of medical treatment. And I think that with this kind of webinar, we can go through the right direction. And I also thank you for all the Jagat and Rasha for giving me an insight, and Amir for organizing this great webinar.
Thank you so much. It was a pleasure. Thank you to SCCT. Thank you, Elucid, for having us here. And I hope that it was a useful 1 hour for all of our listeners. Thank you so much. And with that, we end the session.